ADL subtasks are items that are also included in your late lost ADLs. Specifically, today's training will cover bed mobility, eating, transfers, and toileting, your 4 late lost ADLs. We'll begin with bed mobility. And bed mobility involves how a resident moves to and from lying, sitting, turning, and positioning in bed. While they may typically sleep in a bed, if you have a specific resident who prefers to sleep in a recliner, then you are allowed to consider that as their bed and include how they move in that recliner underneath this late lost ADL. Helping to sit up on the side of the bed, especially that first thing in the morning when the resident is still maybe a little stiff, they're just waking up. Also, when you're swinging a resident's legs onto the bed as they lay down, turning a resident in bed for incontinent care, assisting the resident to pull up in bed, maybe to read or eat, possibly watch television, pulling the resident up in bed if they slide down, pulling up their side rail to use, lifting their legs on a pillow, maybe when you're repositioning on the evening night shift while a patient's in bed, that is included in the bed mobility subtasks. And then just keep in mind about the recliners. Those are included if a resident prefers to sleep in them. So all of the care that you provide while they're in bed or in that recliner, you can include in the ADL subtasks. The next late lost ADL item we're going to discuss is transfers. Some of the items that you may want to keep in mind for transfers is if you have to give that resident a boost. Do you have to just help them one time to reposition and chair? If the answer is yes, then that is one of the subtasks, and you can take credit for that. Supervising and assisting transfers of a resident if they have an alarm, or if they're in a wheelchair and they try and stand up and that alarm goes off, you're allowed to include that subtask. Guiding a resident's bottom into a chair. This is something that we do frequently, and we may not think about that in the actual transfer late loss ADL subtask. When we're documenting in the kiosk, we need to be cognizant of all of the small areas. Even just guiding that resident's bottom down one time, we should take credit for that. Also, setting up the walker or the wheelchair next to the bed and helping the resident steady themselves before, that counts. And also lifting residents' feet into the wheelchair after a transfer. One of the things that I used to do as a CNA, and I remember going up and down the hallways, helping the residents lift their feet up into their wheelchair, and I didn't think a thing about it. But you have to keep in mind that is included in the subtask. And then any transfer via a mechanical lift, we need to keep in mind that it's our policy that any patient that's in a Hoyer lift has 2 staff members with them for safety purposes and to help them feel secure during that transfer. So if a resident is being transferred via a Hoyer lift, 2 staff members should be present, and that is total dependent. And then likewise, if you have a stand-up lift, if the resident is bearing weight, then that would make them extensive, and that would also count for transfers. The next subtask is eating. Eating involves how the resident eats or drinks regardless of skill. So eating and drinking can include the intake of nourishments by other means, such as through a tube feeding or through IV. Now let's look at the subtasks for eating. Setting up a tray, cutting meat, opening the milk, handing utensils, steadying a resident's hand as he or she drinks, providing snacks throughout the day. So if you're giving the patients a snack, maybe you weren't involved in the meal, but you can also take credit for the care that you provide during snack time. Reminding a patient to swallow their food. We see this often in patients who have recently had a stroke. We may see that patient has just discharged from therapy, and we have cues to ask them to tuck their chin and swallow between bites. That's a restorative program that we see frequently. If you're doing that, that counts as an ADL. And then, of course, as we mentioned before, asking your nurses about any IV or tube feedings they may have had. So do keep in mind all of these subtasks. When I see the code of an 88, that means activity did not occur. I often question that and I want to know, is that accurate? And I look at the time of day for the charting just to ensure that we didn't miss an opportunity. The next late loss ADL is toileting. It involves how a resident uses the toilet, bedside commode, bedpan, or a urinal, how they transfer on and off the toilet, how they're cleansed after they eliminate, how we change their pads, and how we manage ostomies or catheters, and also how we adjust clothing. So it doesn't just include one of these items, it's every single one of these. So maybe the patient can do their own transfer on and off the toilets. Maybe they can provide their own pericare, but maybe you have to assist them in changing their pad. Then you would look at that one subtask and determine your most dependent level of care you provided, and you would code for that. So the patient doesn't have to be extensive in all of these areas. You only have to look at each subtask and decide what the most dependent was. Please keep in mind that it does not include emptying the bedpan or urinal or the bedside commode or catheter bag or ostomy. So not how we empty those items, but definitely involves how we are managing those items, meaning the cleaning of those items and if there needs to be any adjustments in the clothing or assistance at the time of care. So very, very specific items in the toileting aspect. And I know a lot of times we just think of, was the resident continent, a bowel, were they incontinent, a bladder? And then we judge based off that when we have all of these different subtasks that actually go into the coding. The subtasks include that incontinent care, removing the brief, applying a brief, transferring on and off a bedside commode or a bedpan, providing catheter care, assisting with the placement of a urinal or the use of a urinal, assisting with clothing, redirecting combative residents during toileting. So if we have to assist a colleague with incontinent care during a behavior episode, that's included in the toileting subtask, or if we're emptying an ostomy. I hope this brief video is helpful in helping to cue you on what areas require additional thought when you're documenting your ADLs.